Let's talk a little bit about breast disorders, in this case, breast cancer, but I'm going to start by doing a little bit of review of the anatomy of the breast. So the mammalian gland is localized over the pectoralis major muscle, and it is surrounded by fat, adipose tissue. The stability of the gland is done by ligaments called ligament of Cooper, and the parenchyma of the mammalian gland is formed by lobules, by lactiferal ducts, and by lactiferous sinus. Let's go a little bit more in deep about this idea. We have little lobules that together will form a big lobe that will be connected to little small ducts, and those little small ducts will connect to a big main duct. At the end of the day, those ducts will collect the milk that will end in the lactiferous sinus, and they will exit in little orifice through the nipple of the gland. So each little lobe or several lobes form a big lobe will connect what we call an extralobular terminal duct that will follow with a segmental duct. This one will follow to a segmental duct and finally to the lactiferous sinus, and we have a collecting duct with orifice in the nipple. This collection of structures belonging to the parenchyma of the breast is what we call the terminal duct lobular unit, which represents the functional unit of the breast. This is an histological picture where you're seeing with the X representing the terminal duct unit. Each X is a terminal duct unit. This is a fundamental knowledge to understand breast cancer. The other thing is to remember, just to review, that the mammary gland is surrounded by main arteries in midline, internal mammary artery and vein, also the axillary artery and vein, and we have the thoracoepigastric vein and the lateral thoracic artery on the lateral side. It is also important to remember that also the breast gland is surrounded by a lot of lymphatic tissues and lymph nodes. In the midline also, the majority of the lymphatic vessels are going to drain to the axilla, and we should be responsible to palpate those lymph nodes located deep and superficial in the axilla, but also supraclavicular, since the ones that are close to the sternum are very difficult to palpate. Mainly, we have several different types of breast cancer, but we're going to focus our attention in two main ones. The ones that are called and depend on the ductal tissue, and the ones that are based on the lobule tissue. So invasive ductal carcinoma are going to be responsible of the majority of the breast cancer, up to 75. The molecular classification will depend on the estrogen receptors, on the progesterone receptors, on the human epidermal growth factor receptor 2, And of course, prognosis will depend if those receptors are positive or negative in the immunohistochemic results. The invasive lobular carcinoma only represents up to 15%, and they have other type of expressions, of gene expressions, mainly the ones that has to do with cut editing. They can be estrogen positive, but usually they are HER or human epidermal growth negative. The invasive ductal carcinoma is going to be hard, irregular mass, and the invasive lobular will be will also form a mass like the ductal, or it could be infiltrative with no distinct mass. That is on the gross anatomy. And of course, there are differences also in the microscope morphology that you don't need to know about this. But what do we need to know is, because it has to do with prognosis, is that invasive ductal carcinoma may spread locally to the skin or the skeletal muscle, but it can also metastasize to the axillary lung or to distant place. In the case of lobular, invasive lobular carcinoma also can metastasize to peritoneum, retroperitoneal, leptomeninges, GI, ovaries, and uterus. There are other references about prognosis that we're going to go covering a little bit in the following minutes. So breast carcinoma can be a ductal carcinoma, a lobular carcinoma, an invasive ductal carcinoma, or an invasive lobular carcinoma. There is in your PowerPoints 2 slides that talk about multi-step model of breast cancer. What I want you to know is very simple. There are 2 distinct pathways of progression. We have low and high-grade pathways. Even though we can have other names of cancer, these are the 2 pathways, and the ones that I'm going to follow with the carcinomas are the ones that I want you to focus on. So we can have a well-differentiated ductal carcinoma in situ, can be low-grade or high-grade. And we can have a lobular carcinoma in situ that can also go low-grade or high-grade, okay? Usually high-grade of a ductal carcinoma in situ or a pleomorphic lobular carcinoma in situ can give rise to high-grade tumors, okay? So the multi-step model just indicates the progression of the cancer. If it decides this growth of abnormal cells, go and take a low-grade pathway or a high-grade pathway. In the case of ductal carcinoma in situ or lobular carcinoma in situ, they can go low-grade or high-grade. The high-grade tumors can be hormone receptor positive, can be HER2 negative, and they can have high proliferation rate. Or they can have a triple negative triple negative basal-like Claudine. These are classifications of high-grade tumors, or they can be HR2 positive. Why do pathologists do this? Because high-grade tumors have different prognosis depending on the receptors that we find, if they're positive or they're negative. In situ carcinoma epidemiology. Overall, breast cancer is the most common cancer in women in the United States. When woman has between 50 and 64 years of age, the risk of ductal carcinoma in situ is very high, 88 per 100,000 women. That is very high. Today, 20 to 25 of breast cancer diagnosed in the United States is ductal carcinoma in situ. And this has increased concurrently with the use of screening mammography. As a significant percentage, the ductal carcinoma in situ is first identified by mammography. But usually in the pre-screening mammography era, only 5% will diagnose as ductal carcinoma in situ. So we're not doing a very good job. We need to keep telling women that they can self-palpate, but the only gold standard screening method is the mammography. Ductal carcinoma in situ can progress to invasive cancer, and it is found that 30 to 100% of this ductal carcinoma in situ, they do progress to cancer if we do not diagnose and we do not proceed to do surgical excision or any treatment. And it's going to do a progression in time in 0.2 to 2.5 years, it will develop in cancer. This means that we still have time to diagnose early and to save life. 2.5 years is a lot of time. Sometimes it's less, only a month, but we still have time. If women do their mammography following the recommendations of Gynecologists Society, we can prevent breast cancer. So the ductal carcinoma in situ is a clonal proliferation, which means that comes from one cell, epithelial cells of the breast, specifically of the ductal lobular unit. And they stay confined in the myoepithelial cell basement membrane. Of course, as I told you, they have the capacity of invade and go out of that little protection of myoepithelial basement membrane. And when it goes out, it becomes invasive. There's some immunostatins that can be performed to show myoepithelial cell retention, to show that still is a carcinoma in situ. There are 5 different patterns of DCIS. You don't need to know this, it's just general information. What do you need to know is that there is 3 nuclear grades. There are low nuclear grades of DCIS. They are characterized by small cells, uniform size. There is an intermediate nuclear grade of DCIS with moderate changes in the nuclear size and the shape of the cells and the amount of mitosis, right? And there is a high nuclear grade of DCIS that is composed by large cells, pleomorphic nucleoli, and frequent mitosis. And this is the one that is more likely to progress to invasive breast cancer. So when we do a biopsy of a ductal carcinoma in situ, in order to know a little bit about prognosis for that patient, we're looking into not only receptors, we're also looking into histology in order to classify it as low, intermediate, and high.